Here are some MCQs. You have to solve this. So first one is, which component of cell wall of mycobacteria facilitates survival of bacilli within macrophage? There are 4 options. One is peptidoglycan, lipoarabinomenon, mycolic acid or arabinogalactan. Which one? No, mycolic acid, actually mycolic acid, action of mycolic acid is not this, but which one? Yes, this is option B, lipoarabinomenon, LAM. LAM is the component of cell wall which facilitates survival of the mycobacteria within the macrophage, right? And which is incorrect about mycobacteria? Which one? Is it circular in shape? No, it is slender long bacilli, right? Bacilli. Is it non-spore forming? So this is an aerobic bacilli, right? Okay. So which one is not an acid fast organism? I think it's D, yes, Tinea solium. Tinea saginata embryophore is acid fast, but not Tinea solium. So which is not true? Secondary TB affects upper lobe of lungs. This is true or not? This is true statement or not? Definitely secondary TB always affects the upper lobe of lung because this is an aerobic bacilli, and at the upper part of lung ventilation is more than the perfusion. Okay? And second one, miliary TB localized at upper and middle lobe. This is true or false? This is false because this is miliary TB spreads via hematogenous route, and at the base of the lungs there are more perfusion than the ventilation. So miliary TB affects more of the base of the lung, not the upper part. C. Ghon's complex include paratracheal lymph node. This is true. Ghon's complex. What is Ghon's focus and what is Ghon's complex? What is Ghon's focus? Ekjon bol. What is Ghon's focus and what is Ghon's complex? No idea. ঠিক করে বল, আমি তাহলে এতক্ষণ কি পড়ালাম, কালকে আগের দিন ক্লাসে কি পড়েছি? What is Ghon's focus? না হলে আমি আর এগোবই না এতে ইনভেস্টিগেশনস। একজন ওট দাঁড়িয়ে বল, কিছুই তো বুঝতে পারছি না। No idea. And what is Ghon's complex? So Ghon's focus is only the granuloma itself. So this is a granuloma, and granuloma plus lymph node, that means this is a Ghon's complex. So the not true is B, right? So what is the annual chance of reactivation of tuberculosis in people living with HIV? Is it 5%, 10%, 30% or 50%? So annual chance of reactivation of TB in non-HIV patients. So what is the rate? What is the annual chance in non-HIV patient? It's less than 5%, 5 to less than 5%, right? So in case of PLHCV, তোরা কিচ্ছু পড়িসনি তাহলে, কিচ্ছু পড়িসনি তাহলে, মানে আমি ক্লাস এগোবো কি করে? নিউমোনিয়া পড়িসনি, টিবির ফার্স্ট পার্টও পড়িসনি, তাহলে আমি কি পড়াবো? এরকম করে জাস্ট ওভার হিয়ার করলেই হয়ে যাবে? এত হিউজ সিলেবাস কভার করতে পারবি তো এক বছরে? তাহলে কিছুই পড়িসনি, কেউ কিচ্ছু পড়ে না। So the chance is 10%, annual chance of reactivation in people living with HIV, and people not having HIV is less than 5%. So most common involved group of lymph node in lymph node tuberculosis. So is it occipital, submandibular, submental or post-cervical? Posterior cervical. Which one? Yes, this is D, posterior cervical group of lymph node. Port spine most commonly seen in upper thoracic, upper lumbar, lower thoracic or lower lumbar? Actually, two of these, among the four options, two are correct, right? So, which one is more correct? Definitely this is lower thoracic more than upper lumbar. Okay, যদি একটা অপশন থাকে, যদি upper lumbar না হলে lower thoracic. Lower thoracic is the most important part of involvement, right? So most common site for abdominal tuberculosis. This is, এখানে কি আছে? Middle ileum আছে, mid part of ileum. Yes, terminal part of ileum and cecum, because of abundance of lymph nodes. Abundance of lymph nodes at the site of terminal ileum and cecum. Most specific ophthalmoscopic finding in miliary tuberculosis, is it papilledema, is it choroid tubercle, iritis or uveitis? Yes, papilledema is the most specific one is choroid tubercle and most common one is papilledema. And the most common type of tuberculosis in people living with HIV, CD4 more than 200. That means almost normal immunity. CD4 more than 200. Is it disseminated? Is it EPTB? Is it miliary TB or none? EPTB, that means extrapulmonary tuberculosis. So this is the most common one, extrapulmonary tuberculosis. And in case of CD4 less than 200 patients, the most common one is miliary tuberculosis and disseminated TB. Now, let's discuss about identification of and investigations of tuberculosis. So, investigation of tuberculosis can be divided into two parts. First one is microbiological and second one is radiological investigation. So, I am talking about microbiological identification, that is seen in the pulmonary tuberculosis and extrapulmonary tuberculosis as well, right? So, what is the cornerstone of microbiological identification? This is sputum smear examination, right? So, sputum smear examination is the most important one, followed by culture. Now, so how to collect sputum specimen? This is very important. Any idea how to collect from your microbiology class? How to collect a proper sputum specimen? Actually, first it should be in empty stomach. It should be at morning, early morning. So why empty stomach? Because if you collect sputum after having food, then there may be some food particle in your specimen that may hamper your result. So first of all, early morning specimen. Second one is fasting specimen. This is very important. And the sputum, the specimen must not contain any hemorrhagic particle. That means the patient is not having hemoptysis. One. Second, the patient must expectorate sputum, not mucus. The yield of bacilli in sputum is much more than that of the in mucus, because the mucus is from the upper respiratory tract and sputum is from the lower respiratory tract, right? And most importantly, we have to collect specimen in two consecutive days, day 1 and day 2. Previously, so before 1992, there was a norm of collecting sputum specimen in consecutive 3 days, 1, 2 and 3. But after RNTCP came, they have instructed to collect the specimen in only 2 consecutive days, day 1 and day 2, and label it as day 1 specimen and day 2 specimen. Both of these should be in fasting state and in early morning sputum. So, if the patient cannot expectorate, suppose you are dealing with a patient of suspecting tuberculosis, presumptive tuberculosis patient, he is having dry cough for more than 2 weeks and fever, but the patient cannot expectorate. So what will you do? There are 2 different options. One is the ideal one, that is bronchoalveolar lavage. So you insert a bronchoscope through the bronchus itself and collect the specimen from the bronchus and alveolar lavage. So this is the most important one, and the yield of AFB bacilli in bowel fluid is more than that of sputum, right? So just it's coming directly from the bronchus, affected bronchus, right? And if you cannot do a bowel fluid estimation, then you should go for sputum induction. What is that? That means the patient is having dry sputum and you have to induce the sputum. How to do that? First, you have to nebulize the patient with a bronchodilator. So after that, you have to nebulize the patient with a hypertonic saline that induces bronchospasm, bronchial constriction, that helps to expectorate the sputum. Okay, so two methods. One is BAL, that is the important bronchoalveolar lavage, and second one is, and next one is, and this is important. So in case of children, specifically less than 5 years old, who cannot expectorate sputum, so the method is, this is not ideal. Gastric lavage is not ideal, because in gastric lavage the positivity chance is less than 50%, because it is often mixed with the gastric fluid and food specimen also. But in children also, the most important and most specific and sensitive one is bronchoalveolar lavage, right? And next is extrapulmonary tuberculosis. So you all know that in certain cases of extrapulmonary tuberculosis, they develop from the delayed immunity, cell mediated immunity, right? So there are granuloma, and after certain period of time, formation of granuloma, and due to hypersensitivity reaction, the extrapulmonary tuberculosis definitely occurs. So in case of, suppose, what are the different type of extrapulmonary tuberculosis? The most one is lymph node tuberculosis. So lymph node tuberculosis is generally from direct seeding of the bacilli inside the lymph node, and also from the delayed type of hypersensitivity. But in case of pleural effusion, pericardial effusion, they are not from the direct invasion of the bacilli into the pleural or pericardial space. Rather, they occur due to hypersensitivity reaction. So in case of this type of EPTB, that means pleural fluid, pleural effusion, pericardial effusion, you may not find direct AFB in smear examination, right? Because these are due to hypersensitivity reaction. But if you are dealing with a case of suspected tubercular meningitis, you have to aspirate the CSF itself, because if the subependymal reach focus ruptures, then the tubercular bacilli directly evade the meninges, causing tubercular meningitis. So if you order CSF culture and CSF backtec culture, then there may be certain bacilli, AFB bacilli. So CSF, one specimen is CSF. Second one is pleural fluid but pus. That means empyema, tuberculous empyema. In tuberculous empyema, you may find tubercle bacilli. Second one is lymph node aspiration and tissue biopsy. So next, how to prepare the sputum specimen? Any idea how to prepare for microbiological identification? How to prepare the sputum specimen? You have heard the name of Petrov's method? Modified Petrov's actually. What is that? This is from your microbiological class, so this is nothing new. What is modified Petrov's method? No idea. পড়েছিস তো মাইক্রোবায়োলজি হয়ে গেছে তো? So actually আমরা কেন করি Petrov's? Because we have to kill the other bacteria and we have to separate mycobacteria, right? So how to kill other bacteria and how to concentrate the sputum? This is very important. So any reagent we have to use in Petrov's method? Any idea? Reagent name? এত ক্লু দিচ্ছি, এটা তো খুব কমন। This is 3 to 4% NaOH. You have to add, right? And followed by in proper temperature, maintain 37 degrees centigrade temperature, followed by centrifugation in 3000 RPM. And that prepares the original sputum, which you have to put in your slide. And this is a modified version of PET-CHOP which involves stopping the digestion process by diluting the sample with water. This is modified PET-CHOP and this is the original PET-CHOP, the above one. The Jadenstein and microscopy procedure, আমি আর বলছি না, so we have already done it in your microbiology class, and this is fluorescent staining procedure. This is Jadenstein procedure and this is fluorescent staining procedure. So what is the utility of doing a fluorescent stain? What is the utility of doing a fluorescent stain? So we have Jadenstein itself. So why we need fluorescent stain? বল, কেউ তো অ্যান্সার কর। সব তো বললাম আগের ক্লাসে, কেউ তো অ্যান্সার দে। Because in Jadenstein there are many false positive results, maybe false positive results such as if the patient is having hemoptysis, then the smear may looks like AFB. But in case of fluorescent staining, this will never happen. So this is the culture media which you already know that LJ media, Lowenstein-Jensen media takes around 6 to 8 weeks, and the colony is rough, dry and raised colony in case of Mycobacterium tuberculosis, which is called as eugonic growth, and in case of Mycobacterium bovis it is called as dysgonic growth. And there are two automated media, but the most common one is Bactec MGIT, যেটা আগে বলেছি Bactec MGIT, and the recent one is Bacti Alert. So the Bactec MGIT actually uses reduction of oxygen as a marker, whereas the Bacti Alert uses production of carbon dioxide as a marker. So both of this media uses fluorescent dye. The NTP, that means National Tuberculosis Elimination Program, recommends doing sputum examination. First, to identify the patient as a tuberculosis patient, right? Second one, to assess the bacillary load itself. Third one, in follow-up and after end of the treatment, if the patient is cured or not. এটা তোরা জানিস, গ্রেডিংটা তোরা পড়েছিস আগে। And now non-tuberculous mycobacteria. Any idea what is non-tuberculous mycobacteria? There are two types of non-tuberculous mycobacteria. One is rapid growing, a rapid grower, and second one is slow grower. So why this is called rapid grower? Because the rapid grower NTM or non-tuberculous mycobacteria shows growth inside the broth within 7 days. That's why this is called rapid grower. And on the other hand, the slow growers takes around 6 to 8 weeks to show a prominent growth in your culture broth. So they are called as slow grower, right? So this is rapid grower organism, mycobacteria, most commonly Mycobacterium abscessus, fortuitum, and these two are the important pathogens, right? And in case of slow growing organisms, most prominent one is MAC, that means Mycobacterium avium complex. Now drawbacks of sputum smear examination. তোদের কি মনে হয় কি drawback? First one is false positivity. Second, most patients cannot expect to read sputum, but whether instead of that they give the mucus or saliva, not the sputum. আর কি হতে পারে, আর কি drawback? Definitely this is very important, not positive in paucibacillary cases. So any example of paucibacillary case? In which kind of patient or yes, definitely, very good. In HIV patients, it is often paucibacillary. So in those cases, the sputum smear may be negative and cannot differentiate between drug sensitive and drug resistant cases. Another very important one is, suppose you are dealing with a case of suspected TB, right? So the sputum smear examination AFB shows 3+ or 2+, but when you go for a CBNAT examination, that means the PCR method, the M tuberculosis complex is negative. The machine cannot find any MTBC gene. But sputum smear examination is positive and CBNet is negative. That means maybe you are dealing with a case of non-tuberculous mycobacteria, NTM. So sputum positivity, CBNet negativity simultaneously. Generally, it is a case of NTM or non-tuberculous mycobacteria. So it is not specific or sensitive. And definitely there is no role of EPTB. Now, because of these fallacies, the molecular methods are invented, right? So molecular methods, mainly they are based on PCR technology, polymerase chain reaction. Any idea PCR কিভাবে act করে? Basically targets a gene and separate that gene and proliferate, right? Replicates that gene. This is a short version of PCR. So this is the first line investigation. Nowadays, according to the recent guideline, this is the first line. In every patient of suspecting tuberculosis, you have to do CBNet examination. Along with that, sputum smear. And there are different types of molecular method. CBNet and TrueNet is a PCR method. CBNet, what is the full form of CBNet? Very good. Cartridge based nucleic acid amplification test. Okay. So TrueNet is less specific than that of CBNet. So CBNet, in CBNet, there are actually, কেন CBNet করব? Why it is recommended as a first line investigation? Very good. Reform patient resistance. Because in India, what we have found in last decade, that there are absolute rise of drug resistant tuberculosis, because of they are not detected at early stage, right? That is the reason they have implemented this. Because in CBNet, তোরা যে এখন মানে first one in one case you have to identify the MTBC, Mycobacterium tuberculosis complex. In second phase, there is a chance of identification of rifampicin resistance or rifampicin sensitive gene. This is important. LPA, what is LPA? Line probe assay. So what is the utility of LPA over CBNet? Very good. Beside the RR, rifampicin resistance, LPA detects isoniazide resistance. Not only isoniazide, আমি বলবো আরো পরে আসছে. There are two types of LPA, one is FL LPA and one is SL LPA, first line and second line LPA. Okay, so LPA is important. And LAMP, that means this is not nowadays actually আমাদের এখানে available নয় ইন্ডিয়াতে, but LAMP করা যায়, ঠিক আছে? And this is the integrated management of algorithm of TB, right? So if you are suspecting a case, that means this is a case of presumptive tuberculosis. In all cases of presumptive tuberculosis, CBNet at the first line, X-ray and CBNet is important investigation, the first line investigation. Okay, then CBNet. Kono idea CBNet? What is the principle of CBNet? কিভাবে CBNet করে? First, isolate the specimen. Okay, আমি ডিটেইলসে কিছু বলছি না, অত ডিটেইলসে তোদের জানার দরকার নেই, but you need only 2 ml of sample. Okay, just 2 ml. 2 ml of sample is being processed, right? First, next, that 2 ml sample is processed via centrifugation and other procedures. The specific gene is identified and amplified. Okay, and after that, after you find a specific gene in that present in Mycobacterium tuberculosis, then you should find a RR, rifampicin resistance gene. If it is not found, then you should mention RR not found. So the gene which is amplified is RPOB gene to detect rifampicin resistance. So there are 5 different types of gene that encodes different types of drug resistance. Every drug has its own genetical resistance. So result is within 2 hours. Okay, so this is the quickest method. Which sample can be processed? One is sputum, most importantly, bronchoalveolar lavage fluid, you can process it. Second one is pleural fluid, CSF, biopsy material, but never use blood or urine sample, even stool sample also cannot use. This is the method of CBNAT. Next one is line probe assay. তোরা যেটা এক্ষুনি বললি line probe assay, what is the benefit of line probe assay over CBNAT? That indicates additional resistance, detects additional isoniazid resistance over the rifampicin resistance. But the most important thing before doing an LPA, this is the sputum smear must be AFB positive. In case of AFB negative sputum, you cannot do an LPA. Fine. There are two types of LPA, one is FL and one is SL. FL is for the first line drugs. What are the first line drugs? One is isoniazid, rifampicin, pyrazinamide, and ethambutol, right? So there are two very important genes that encodes the isoniazid resistance as well as the ethambutol resistance. One is INHA and another one is CAT-G gene. These are the most important one. So FLLPA targets or amplifies INHA gene and CAT-G gene, right? In case of SLLPA, there are different types of gene. That means GOIRA that encodes fluoroquinolone resistance. EMBB that means ethionamide resistance. So these are the different types of genetical targets. And this is the LAMP. This is also a NAT test, point of care test, rapid test, but this is not done in India right now. Lipoarabinomannan test. So the sample needed for lipoarabinomannan test, which is the sample? Urine. This is also a point of care test, and the urine is the sample from which we can detect lipoarabinomannan is the component of the bacillary cell wall. So we detect that cell wall inside the sample. Now latent tuberculosis. What is latent TB? Any idea? What is latent TB? একটু জোরে বল, কিচ্ছু বুঝতে পারছি না। No, secondary tuberculosis is different thing. Latent TB is different thing. আগের দিন একটা ফ্লো চার্ট দেখিয়েছিলাম না, যেখান থেকে তোর অ্যাক্টিভেশন হচ্ছে, রিঅ্যাক্টিভেশন হচ্ছে, সেখানে ভেরি গুড। দ্যাট মিনস TB bacilli is present but it's not infecting or it's not activated or it's not multiplying. This is latent TB. Any of us may have latent TB. We don't know actually. And in case of each and every latent TB patient, there is a chance, always there is a chance of reactivation. কখন reactivation হতে পারে? Definitely if the patient is being immunocompromised. One. Second one, in older age, because there is a immunosenescence in old age. And if the patient is getting immunomodulator drug therapy, then the latent TB may be reactivated. So in latent TB, the patient is not developing any symptom, the radiological investigation is absolutely normal, the sputum examination is normal, right? Whether in TB disease, all these things are abnormal. Definitely there are risk factors. So diabetes mellitus, CKD requiring dialysis, people living with HIV, recent contact with active HIV patient, active TB patient, and drug or alcohol users. These all are the risk factors of reactivation of tuberculosis. And how to diagnose latent TB? Name two diagnostic method of latent TB diagnosis. MANTU test, right? And another one is bol ঠিকই বলছিস হ্যাঁ IGRA, right? Very good. One is MANTU and another one is IGRA. So what is the method of doing a MANTU test? Any idea? কি করে করে বল বল 2 tubercular unit of PPD, purified protein derivative, insert করতে হয় intradermally and at the flexure surface of the forearm. The skin should be devoid of any scar or any tattoo mark. Okay. After that, after inoculation, the diameter of induration, not the erythema. This is important. Not the erythema, but induration is important. Measurement of after 72 hours. What is the measurement? More than 10 millimeter, that means this is positive, and more than 5 millimeter in children and people living with HIV. This is positive, right? What is the mechanism behind MANTU? একটু ডিটেইলে বল ঠিকই hypersensitivity type of মানে কি type of hypersensitivity হ্যাঁ and কি কেন হয় basically after you are injecting a PPD, after you are injecting a PPD, antigen presenting cells take up the antigen, CD4 plus T cell activated, which creates the delayed cell mediated immunity. Okay, but there are certain fallacies. So কি fallacy থাকতে পারে MANTUর জন্য? MANTU may be false positive and false negative. This is neither specific nor sensitive. Why? What is the cause of false positivity in MANTU? BCG vaccination. Very good. Second one, non-tuberculous. Very good. One is BCG vaccination and another one is NTB infection. That can lead to positive result in MANTU. And what are the examples of false negative result? Immune suppression patient আর কি হতে পারে? In case of sarcoidosis, MANTU may be false negative. Even after more than 10 millimeter, you cannot find. After giving 10 TU, okay. So this is not sensitive, not specific. But the sensitive one is IGRA. Why IGRA is sensitive more than that of MANTU? Because IGRA, actually in IGRA, what we do? We extract the two different antigens that is specific in Mycobacterium tuberculosis. One is ESAT6 and another one is CFP10. So ESAT6 and CFP10, these are the two antigens that present inside the Mycobacterium tuberculosis. Definitely they are specific, and the process is same as like process that the mechanism is same, just delayed type of hypersensitivity just like MANTU, but IGRA is done from the blood, right? This is more specific. Now radiological investigation. The most important radiological investigation is X-ray. So X-ray, HRCT thorax and ultrasonography. These are the types of radiological investigations. So in X-ray, what is this? This is primary tuberculosis, Bones complex, enlarged hilar lymph node. This is cavitary pneumonia, cavitary tuberculosis, secondary tuberculosis, upper lobe and cavity. And this is pleural effusion. This is lung abscess. This is lung abscess. হয়ে গেছে পড়ানো. Air fluid level inside the cavity. This is lung abscess. And this is miliary tuberculosis. This is এটা কি? Ring enhancing lesion, tuberculoma, CNS tuberculoma, cerebral tuberculoma. and these are the different types of extrapulmonary tuberculosis. এটা তোদের বলেছিলাম যে what are the symptoms of suspect, whether you should suspect a case of CNS APTB, extrapulmonary tuberculosis. But একটা জিনিস মনে রাখবি, in all case of EPTB you must do IGRA and sputum smear examination. So these are the এগুলো তোরা নোট করে নিতে পারিস, খুব ইম্পর্টেন্ট একটা স্লাইড। বেসিক্যালি আমি আগের স্লাইডে আগের যে ক্লাস ছিল সেখানে আমি সব এক্সপ্লেন করেছি। লিম্ফ নোড টিউবারকুলোসিস, হোয়াট আর দ্য ইম্পর্টেন্ট ম্যানিফেস্টেশন অফ লিম্ফ নোড টিউবারকুলোসিস অ্যান্ড ইম্পর্টেন্ট ম্যানিফেস্টেশন অফ সিএনএস টিবি, এগুলো সব আগের দিন আমি মেনশন করেছি।